Hey students, this is Dr. Tatum here. Um, I hope you guys are all doing well. I want you to know that I'm thinking about you and I'm praying for you, and you are not alone. We are in this together. As I said in my discussion post, I've never taught Nursing 360 online. So this is something new for me as well. So I just ask that you bear with me, give me grace, and I will give you grace. Um, I am currently doing this recording in my basement because I have 3 children running around crazy upstairs. So I apologize in advance for any interruptions. Hopefully not. But what I'm going to do is I'm going to start with chapter 22, and I'm just going to walk you through different pieces of chapter 22. And this video is primarily going to be over preterm labor. So if you guys would like to get out your PowerPoints, and I'm going to start on slide 3, where it talks about preterm labor in general. So bear with me as I advance my slides here. Here it goes. All right, so with preterm labor, we've talked a little bit about preterm labor before. Preterm labor is when a delivery occurs before 37 weeks gestation. And so really, what happens is a woman will start to have really intense labor contractions. And those intense labor contractions become painful, and that will push the baby down towards that cervix, and that cervix begins to open up. So it begins to dilate and efface all before 37 weeks gestation. So preterm labor can be scary just because these babies are pretty immature. They have immature body systems, and if we think about their lungs, a lot of times their lungs are very immature, not enough surfactant is present, and so we worry about respiratory distress, and we also worry about cold stress in these babies. So of preterm deliveries, about 75% of babies are a late preterm baby. And a late preterm baby is born between 34 and 36 weeks gestation. These babies still have issues with temperature, so they are more predisposed to cold stress. The transition period is a little bit more prolonged for them as well, just because they have a harder time eating and breathing at the same time. So I just want you to know a baby born before 32 weeks gestation, those babies have a higher morbidity and mortality rate just because those lungs are so immature. So let's keep moving. We'll move on to slide 4. All right, so as I talked about before, just because the preterm birth is more dangerous, these babies are more predisposed to immature body systems. They just cannot regulate their bodies the way that we need them to, specifically their lungs. One definition that I really want to describe to you is low birth weight. So a low birth weight baby does not mean that that baby is preterm. A low birth weight really describes a birth weight that is 25 grams or less. So really it's about 5.5 pounds. This is a little bit easier to measure than preterm birth. Babies that are term, so if they get to 40 weeks, they might have a low birth weight. Maybe they had intrauterine growth restriction and they just weren't growing the way we needed them to in utero. So there is a difference between a preterm birth and a low birth weight birth. And I think it's important to understand the difference between those two terms specifically. So again, a preterm birth is more dangerous because body systems are very immature. So again, it's a delivery that happens before 37 weeks gestation. With a low birth weight baby, a low birth weight baby might get to term, so might get to 40 weeks, but still weigh very, very small. So 5.5 pounds or 25 grams or less. These babies might have mature body systems. They're just very, very tiny. We'll keep moving along and we'll go to slide 5 here. So there are 2 categories of preterm births. There are spontaneous and also indicated. A spontaneous preterm birth is basically when the body actually initiates the labor process. So moms start to have uterine contractions that become more frequent and more painful. And because of that, that cervix starts to open up, efface and thin out, and then also dilate. So 75% of all preterm births are spontaneous in nature. So what would be some risk factors that could cause a spontaneous preterm birth? Just thinking about certain things, infection could be a potential risk factor. So maybe a genital tract infection, maybe a sexually transmitted disease. Um, a lot of times a multifetal gestation, so twins or triplets. Sometimes it's second trimester bleeding. So mom starts to spot a little bit more in her second trimester. It could be low pre-pregnancy weight. Maybe mom was quite small before she got pregnant, maybe very, very thin and didn't have enough nutrients on board. And because of that, that has then led to a preterm labor. And then a lot of times moms that have had a history of preterm birth, they are at highest risk with their second, third, and fourth babies as well. So they need to be monitored very, very closely. There's one term on here that I wanted to point out to you on your slide, an amnionitis. Amnionitis is basically infection that surrounds the amniotic membrane. So the membrane that holds all of the amniotic fluid in place. And sometimes that can become infected as well. And then it leads to infection in baby. So mom and baby both are infected, and that can result in preterm labor. An indicated preterm birth just means that mom is having a lot of risk factors that put her at risk for a preterm birth. So it can affect both the mother and the fetus. So diseases that affect mom might be preeclampsia. It could be diabetes. It might be just regular diabetes or gestational diabetes. It could be a placental abruption, meaning that the placenta has detached from that uterine wall. And now all of a sudden we've cut off the life supply to baby. It could be kidney disease or renal disease. So there's lots of different risk factors that coincide with an indicated birth. So an indicated birth means that because of these risk factors, we need to get baby out. And so the obstetrician will say, okay, um, you know, we know that this baby is only 35 weeks, but we really need to take baby out because of these certain risk factors. So that is something that you're going to see in the prenatal history. That's something that you're going to be watching for on admission. So just keep that in mind. All right, let's move on. We'll move on to slide 6. All right, so as far as other specific factors, there are certain biochemical markers that we utilize to see if a mom is at high risk for preterm delivery. So if she comes in and she's contracting, the doctor might order a fetal fibronectin, which is a biochemical marker. A fetal fibronectin basically is when we take a swab. So we swab basically around the cervix and during a vaginal exam. And so we basically take a sample of that fluid that's surrounding the upper part of the cervix and the vagina. And what we're looking for is a specific glycoprotein that's found in the plasma during fetal life. And a lot of times, if that fetal fibronectin is negative, meaning that there's no fetal fibronectin found on that swab or collection of amniotic fluid, then that means that mom is not a high risk for preterm labor, which is good. We want to know that. We also look at the cervical length. So a lot of times we can measure the cervical length and we look for any specific changes in cervical length. Usually if the cervix is greater than 30 millimeters in length, then she is not at risk for preterm labor, which is good. All right, let's keep going. We're going to move on to slide 7. All right, let's look at the causes of preterm labor and birth. So like we said before, infections. So infections like urinary tract infections, sexually transmitted infections, all put her at highest risk. Also bleeding at the placental site of implantation. Sometimes just that bleeding can activate that labor process because of inflammation. And then other things, maybe she is just low in progesterone. So think back to what you know about progesterone. It's that hormone in the body. Hormones like progesterone help maintain a pregnancy. So it relaxes the uterus, which is so good. And basically, it helps build and maintain a healthy uterine lining. If moms don't have enough progesterone on board, then all of a sudden they can start contracting. So it's really important for moms that have had preterm labor before. A lot of times they're going to be monitoring those progesterone levels. And if those progesterone levels are low, then they might start them on vaginal suppositories that contain progesterone. And she might use these daily. She might do weekly IM injections of progesterone as well. And so, again, a lot of times this is used for moms that have had preterm deliveries before. But there are things that we can do to help decrease the chances of preterm labor occurring. All right, we're going to keep moving. We're on slide 8 now. So this just shows a picture of the different factors that are in place for preterm labor to begin. So like we talked about before, progesterone levels can decrease. The cervix might be incompetent, meaning that it starts to open up very, very early during pregnancy. And sometimes just the weight of the fetus can cause that cervix to open up and thin out. And then the result is an imminent delivery. Other things like stress, infection, it could be vascular disorders, it could be just aging of the lining of the uterine wall. Sometimes that occurs. So that's what decidual senescence means. And then uterine overdistension might be a multifetal pregnancy. So lots of different things that are in place that can predispose a patient to preterm labor. We're going to keep moving. Let's move to slide 9. All right, so how do we prevent this? We educate patients about this a lot. On page 60, or I'm sorry, on page 680 in your book, there is a teaching box, box 22-3, that talks about the symptoms of preterm labor, and we're going to teach our patient this. So the things that we want to teach her is that if she starts to have more and more uterine contractions, and they're becoming more frequent than every 10 minutes, and they're lasting at least an hour at a time, or in length, I should say, not one contraction lasting an hour, but if they're occurring over an hour time period, that puts her at high risk, and she needs to know that. If her contractions become more and more painful, if she's got lower uterine abdominal cramping, maybe if she's having any diarrhea, any GI problems, if she's having dull intermittent back pain, if she's having like terrible menstrual like cramps, those are another indicating factor of preterm labor. If she's just feeling a lot of pressure, like a lot of suprapubic pain, then that's another thing that she's got to be aware of. And then obviously, if she feels any continuous leaking or trickle of fluid, that could mean that her bag of water has broke. Or if she's just sensing that her vaginal discharge is more heavy in nature, then she really needs to call her doctor. And so, what do we tell her to do when all of these things occur? Well, first of all, if she's having uterine contractions, we want her to have an empty bladder. So tell her to go to the bathroom. We also want her to stay hydrated. So we want her to drink some water, at least 2 to 3 glasses of water or juice. We want her to lay down on her side for at least an hour. And if she is having contractions, she needs to palpate them. She needs to time them. And then if her contractions are becoming more intense and they're lasting longer than an hour, then she needs to call her provider right away. Also, she needs to make note of any vaginal bleeding, again, any odorous vaginal discharge or fluid leaking from her vagina that could indicate her bag of water has ruptured. All right, we're going to keep moving on. I think I'm going to stop there for right now just because I think that my recorder is going to stop me at 15 minutes. So I will pick up where we left off in just a moment. Thank you for bearing with me.